Hey, this is Anmashi Maroda from Group SWML13, and we are going to be talking about malaria drug resistance risk in HIV positive patients. What this means is that um, these malaria parasites become resistant to the antimalarial drug. And this is because they keep on mutating, and when you increase the pressure you're putting on them, that is the drugs that you give them, they eventually become resistant to that drug. And so this becomes a very high risk in HIV patients since their immunity is already compromised. So what we're trying to do here is predict if this particular HIV patient or the region they are in, if the anti-malaria drugs will become resistant to them. Yeah. So these are the contents of our presentation today. And our background is Africa. We know that malaria and HIV are very rampant in Africa. And so they are co-infection. If you have HIV and then because you have a compromised immunity, you get infected with malaria, you're going to be very healthily challenged. And so we're trying to see if these malaria treatment drugs they give you are going to help you or if they're going to just worsen your condition. And these are our recent trends and literature review. We see that with HIV immunity suppression, there's associated high prevalence of malaria. And so that increases parasite density and higher risk of anti-malaria treatment failure. We have the ACTs like AL and DP that are effective in HIV patients, though DP has lower rates of parasitical failure. We've divided our problem into the computational problem and the domain application problem. In our data sets, we have these different variables, and we see that if you're given all these variables, can you predict that the percentage or the probability that the anti-malaria treatment will fail in an HIV patient or it won't? Yeah, and so the domain application and says that clinicians, or should we say doctors and nurses, currently they rely on general population treatment failure rates, but then they don't distinguish the HIV immunity status and they don't take into account the genomics or the genes of the malaria parasite that tries to become resistant to the anti-malaria drugs. So what we're trying to do is to look at how these parasites mutate, how their genes change, and then predict if the anti-malaria treatment will work on this HIV patient who has a compromised immunity or it won't. And our research questions and objectives are to determine the correlation between CD4 count and the anti-malaria treatment failure risks, to identify the specific drug with the highest effectiveness across HIV immune tiers, and then to map geographical regions where HIV prevalence and anti-malaria resistance mostly overlap. Then we're going to determine if patients with weak immune systems have to be moved to stronger backup treatment. And then our outputs are going to be a predictive failure risk score that integrates current CD4 counts with regional resistance markers, to quantify how specific immune tiers directly correlate with anti-malaria treatment failure. So we built a mapping tool that is drug effective, and it identifies ACT treatments and then maintains the highest clearance rate. Then we map high risk overlap zones by linking regional HIV prevalence with localized data on the resistance treatment. And then we proposed a system to help HIV positive patients get the right medicine. So these are the methods we are using and the system architecture. First, we are going to do data ingestion. We are going to bring in the data into our system or our working area. Then we are going to pre-process it, remove the missing values, and change the data types so that the model can use the right data types. And then we are going to go on and carry out a machine learning based EDA. And then we shall carry out interpretation and deployment. So I'll give to my colleague to continue. Thank you.
Hello everyone, my name is Aruho Prisla, and I'll be taking us through dataset description and EDA. And the EDA. So our dataset is a merged clinical dataset of information from patients in regions where HIV and malaria are co-endemic and co-infectious, and how HIV-positive patients respond to anti-malaria treatment. And we got this from combining 3 different datasets that are from 3 different sources. One of the datasets is from Malaria Gen. It looks at mostly malaria genomics. And then we have the IDH and the MTM, all with different purposes, granularity, primary keys, and autocolumns. Our EDA brought us to visualization of the merged dataset. And in this visualization, we see that we have immune suppression significantly increasing malaria treatment failure risk, particularly in regions with high drug resistance. We also found out while carrying out this that patients with severe immune suppression have higher median failure risk scores. The advanced host stages and low CD4 counts are associated with increased failure risks. So the regional drug resistance, the sulfadoxine and piperaquine, correlates with higher baseline failure rates. And we can see that here. Then we also look at the immune recovery through ART, which reduces malaria treatment failure here in this particular visualization. So factors like age and blood groups also affect the risk, the failure risk score to immune status and drug resistance. They also look at the years one has been on ART and the failure risk score and how they increase in this scatter plot. Then we also look at the levels of HB, hemoglobin, and hemoglobin and the failure risk score. Then we also look at the white blood cells versus the failure risk score by host stage. Then these insights suggest that clinicians should consider immune status when selecting anti-malarial therapy, especially for HIV-positive patients in high resistant regions. Also, that second options should be brought forward for people that have a high risk of like the failure risk with failure risk score that is high. Second options of treatment should be given to them, and we can tell from the different visualizations. So next will be the semi-supervised learning that we performed on this on the data set, and it will be presented by the next presenter. Thank you.
Hello everyone, this is Arije Docas. I'm going to take you through some supervised learning and the other parts. So this slide provides a high-level overview of a semi-supervised learning workflow, demonstrating how a model can learn from a small amount of labeled data to categorize a much larger set of unlabeled information. So here is a breakdown of the process as it appears from left to right. The starting point, data scarcity on the far left, we see the initial data set. Out of 761 total samples, only 161 are labeled. This is a classic real-world scenario where manual labeling is expensive or time-consuming. The goal is to use those 161 samples to predict the remaining 447. Then the initial training state, and the top center scatter plot shows the initial training state. Yeah, you notice the red dots which are labeled are sparse compared to the gray dots which are labeled. Then in the first iteration, it adds 179 new labels by making high confidence guesses and labeled data, a process often called pseudo labeling. By the end of the 10 iterations, the model has exhausted its learning gains. Then measuring performance, the right slide of the side evaluates how well the model performed, especially well on class 2, 89 correct predictions, but we see some confusion in class 3, where it frequently misclassifies samples as class 2. The final accuracy, the model achieved an 82.35% final accuracy, while the precision for classes 2 and 4 is high. So class 1 shows a precision of 0.0, suggesting the model struggled with very rare or difficult to distinguish samples. Then the final outcome, the bottom right plot represents the final state. The previously gray unlabeled data is now color-coded into 4 distinct clusters. This visual confirms that the semi-supervised approach successfully mapped the structure of the entire dataset using only a fraction of the original labels. So by iteratively labeling its own data, the model grew its knowledge base significantly, resulting in a robust classification system with over 82% accuracy despite starting with limited information. Then next, first, our machine learning driven data cleaning revealed something critical. 26% of the genomic samples over 8,500 records were essentially noise with no detectable resistance signal. So traditional methods would have missed this. This would have seriously degraded model performance. And second, we established a feature signal hierarchy. Drugs like artemisinin and chloroquine showed high data integrity, above 86%, making them reliable predictors. And on the other hand, mefloquine was flagged as a weak feature, meaning it may not be trustworthy for modeling. Then we uncovered a significant interaction between immunity and resistance. In our HIV-positive cohort, nearly 28% had malaria infections, and patients in advanced World Health Organization stages showed a much higher risk of treatment failure. So that supports including an immune compromised interaction team in our model. And finally, the data confirmed that treatment failure is highly nonlinear with the 55% of cases showing the 0 failures. That means standard linear models just won't work. This validates our decision to use the machine learning. And that said, we do have some important limitations to acknowledge. We have geographic blind spots, regions in Uganda that have plenty of clinical data, but very few genomic samples. Also, any genomic data older than 2010 is outdated and had to be excluded. So our model is also specific to P4 param, so it won't apply to other malaria species. And finally, that 8 records with an ambiguous country code remain unresolved, which introduces some geographic uncertainty. So overall, these insights give us a strong foundation, but they also highlight where we need more data and caution interpretation. And the next steps, validate models using recent global data sets from 2021 to 2024 to reflect evolving parasite resistance. Then if we have recommendations, we have expands in supervised learning to utilize enabled clinical data. We have prioritized research on moderate and severe immune tires with higher failure risk. Enhance feature engineering for HbWBC. These are the white blood cells and platelet indicators. Improve predictive modeling of high-risk immunocompromised patients. Integrate model findings into public health policy and treatment guidelines. So our references were the Uganda National Council for Science and Technology, then the National Institutes of Health, the Malaria Gene PF8, DIRAD, then the WHO, World Health Organizations. Thank you for listening.